Namaste and greetings. I, Tanu Paliwal, researcher at IMPRI, Impact and Policy Research Institute, Prabhav एवं नीति अनुसंधान संस्थान नई दिल्ली extend my warmest welcome to you all to IMPRI Web Policy Learning. Today marks the second day of Health Sector Management and Governance, an Indian Perspective, an online national summer school program, a 1 month immersive online certificate training course. This training program is organized by IMPRI, Center for the Study of Finance and Economics, CSFE, IMPRI Web Policy Learning. This program has an excellent panel of experts who will be sharing their expertise for the duration of this program. The expert panel includes Professor Mukul Asharji, Mr. V. Ramakrishnan ji, Dr. Parashram Patil ji, Dr. Manorama Bakshi ji, Ms. Urvashi Prasad ji, Professor Pradeep Panda ji, Professor Sangamitra S. Acharya ji. The panel of conveners comprises of Dr. Simi Mehta ji, Dr. Arjun Kumar ji. The chair of the program is Professor Mukul Asharji, former professor, Lee Kuan Yew School of Public Policy, National University of Singapore, visiting distinguished professor IMPRI. Proceeding further, I welcome all the participants to this enlightening deliberation and thank you for being interested and putting your time, energy, and efforts into learning, sharing ideas, and contributing to the evolving landscape of healthcare management and governance. We have also shared the course outline and reading resources in your email. Before we start today's program, I would like to remind the housekeeping announcements once again. Please join the meeting on time. There will be question and answer session after each presentation. Share your questions on the question and answer box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise. Refrain from making general comments in the question to save time. Now, without any further delay, let us start with our program. It's my honor and privilege to invite Professor Mukul Asharji, former professor, Lee Kuan Yew School of Public Policy, National University of Singapore, visiting distinguished professor, IMPRI, to give his kind remarks. We welcome you, sir.
Thank you. Namaste. Pranam to everyone. Last week, we had introduction to the course, and we started with the analytical frameworks. As they say, nothing is more practical than a good analytical framework or a theory. Reality is complex. If you have a bad framework, the more brilliant you are, the more damage you do. So it's very important to understand those frameworks. Now, we did not complete the frameworks, which we'll do in the next session. Today, we move on from last time, and we have two very India-specific presentation. The first by Urvashi Prasad from Niti Aayog on India's recent and proposed healthcare initiatives and development. India, we know, for a long time did not regard health sector in a professional management perspective, hence this course. So we are now looking at a lot of initiatives that are trying to overcome our legacy issues in healthcare, and Urvashi will provide an overview of that. The second is that India is unique in having Ayush ministry. So while we have, we do use, of course,
Sir,
the
hello, sir. Sorry to
medical.
disturb you. But
Yeah.
can you please adjust your camera? We cannot see your face.
Sorry.
Can you please adjust your camera? We cannot see you.
Oh, sorry. I think
No problem.
camera fell off. Okay. But you could hear, right? So India is unique in having Ayush ministry. So even as we do the allopathic, we do the normal global medical practices, we also have, as an ancient civilization, a lot of our own medical systems. The idea is not whether, the idea is land, how to complement respect for both. So we have Pradeep K. Panda, who will discuss the role of Ayush in India's healthcare. How are we using that, Ayurveda, Unani, and so on? How we are using that to complement the uh, the traditional healthcare systems. So we can move forward and have Urvashi make her presentation.
Okay, thank you so much, sir, for giving your kind remarks and giving an overview of today's programs. So it's my honor to invite Ms. Urvashi Prasad ji, Director, Office of Vice Chairman, Niti Aayog, New Delhi, for the session on India's recent and proposed healthcare initiatives and deliberations. We welcome you, ma'am.
Thank you. Thank you. So can you put up my presentation?
Sure, ma'am.
Yes. You can see
Yeah.
it?
Yes, yes. Yeah. So today, thank you very much for having me, and thank you to Professor Mukul for that introduction and that overview. So today I'm going to talk a little bit about where we've come to in our health system in certain areas. It's not fully exhaustive or comprehensive because that would take a lot of time to cover everything. But certain areas which I think are important that I picked, the present and how I see the future from the policy point of view. So next slide, please. So I think one overarching shift that we are clearly seeing in the health system in India is from a very cure-focused, hospital-based health system to one which is focused more on health promotion and prevention. And I guess that's also where the Ayush piece later on will come in, because certainly yoga, for instance, has a big role to play. Yoga, meditation, all of these in just promoting mental well-being, even physical well-being. So that is the shift that I think the health system is now trying to make, wherein only people with, acute illness, people who need to be hospitalized, actually go to hospitals, whereas others we keep out of hospitals. And at most, if they need to go, they go to a primary health center. So we are setting up health and wellness centers under Ayushman Bharat for that. So here, what I'm really talking about is this shift, and also the fact that now with this shift, there's going to be a scope for more remote monitoring of patients, constant monitoring of patients, especially those with chronic conditions. And these, and I'll talk of technology in the next slide and how technology is playing a role. But basically, the idea is that the devices we see, for instance, today, the smart watches, the smart trackers, which are limited to a reasonably affluent urban segment, that is going to expand. And definitely, that technological innovation is going to reach out to many more people. It's going to become more affordable, more accessible. So I think that is a shift that we are making, that instead of everybody all the time coming to a hospital to get checked out, we would have these remote devices which will be able to constantly track and monitor the conditions of people who have chronic ailments. So next slide. So this is what I was coming to, that technology will play a disruptive role in the entire ecosystem, right from early detection to helping doctors make better decisions, interpreting radiological tests and images in a much more efficient manner and much more accurate manner. I think precision diagnostics, precision decision making technology will play a very big role. But also then coming to the treatment part, and like I was mentioning in the previous slide, the wearables, the smart sensors, etc., which can allow remote constant monitoring and going right through to end of life care. So technology, it's not the end in itself, it's a means to an end, but it's going to be a very important enabler for sure. It's already playing a big role, and it's going to play a bigger role in the years to come. So next slide. Now, this is one big area that we are focusing on, which needs a lot of more work, is that most of our, especially when we see hospitals, hospital beds, there is still a concentration in the larger urban centers. So there is a need to move into the tier 2, tier 3 cities, towns, urban areas, rural areas, remote areas. So that is the push that the government is trying to make, but a lot of that has to happen through public-private partnership, because we do have a substantial private sector in health, but a lot of it is informal, a lot of it is not very organized. So there is a push to try and integrate some of the smaller providers in the health sector with the public health facilities as well, and eventually to also incentivize private players to set up hospitals in the smaller locations in the country. So I think that is one big focus. Also, the nature of the hospitals is going to change quite a bit. And, since you're talking about Ayush later, I have a point here that integrative medicine departments are going to become more common in hospitals. We are already seeing some of the bigger hospitals, they already have integrative medicine, what we call integrative medicine, where you are combining modern medicine approaches with yoga and Ayurveda, etc. So I think that is going to become much more common, as will specialities like palliative care and psycho-oncology, because right now these are fairly limited. Palliative care, most people understand as end of life care, which is not true. Palliative care happens throughout somebody's treatment. And the idea is that they should not be in pain, they should not be in suffering. So that is the main idea of palliative care. It's not just end of life care. So that I see expanding. Psycho-oncology, which is not really a developed speciality at all right now, as more and more people are unfortunately getting ailments like cancer, the mental health issues associated with that are becoming more important. And so psycho-oncology will also be much more in demand. And then, of course, the medical devices and also the drugs, these need to be made available. We need to have indigenous manufacturing of these drugs and devices. So, of course, the government has provided a production-linked incentive scheme for manufacturers. But there's various other initiatives which are also underway to try and boost the indigenous production and make sure that people in every part of the country have access to these medical devices and to the drugs. So the next slide, please. Now, laboratories and the screening space, that is also going to get disrupted. It's already changing. Now people are seeing a greater demand for preventive screening and wellness packages. Earlier it is mostly been curative, that you fall sick and then you go, you try and get a blood test done or you get some tests done. But now a lot of people at an individual level, as well as employers for their employees, are seeking preventive screening and wellness packages. And I already spoke about the advanced and precision diagnostics, but also screening that we can do for large parts of the population. I think from a government's point of view, this is a big focus area. Through the health and wellness centers in Ayushman Bharat, we are trying to ensure that we can screen large numbers of people for cervical cancer, for breast cancer, oral cancer, and various other common health issues. So we do need, medical devices again for that, which are affordable, which are easy to use, which are customized to our socio-cultural context, and can be scaled up rapidly. So I think there's huge scope in that area. There's a startup, for instance, which is using artificial intelligence to interpret X-rays in a much more precise manner. And so now through those X-rays, not only is it possible to diagnose conditions like TB, much faster. Normally TB diagnosis obviously, takes a long time. But now it's much quicker using AI through on those X-rays to identify whether it's TB, whether it could be lung cancer. And of course, they had developed this during COVID and used it on a large scale then. So there's many startups like that. And I think we need such solutions, which we can eventually scale up and screen large parts of the population. Because again, the concept here is that you cannot put everybody into a hospital. We have too large a population. So we cannot wait for everybody to fall sick and put them in hospitals. We have to focus on prevention. We have to focus on early detection. And that is where the whole shift is happening. Next slide. So virtual healthcare, post-COVID, this is becoming very, very important, right from telemedicine, where now a lot of people are using telemedicine because it's convenient. You can do it from the comfort of your home or wherever you want to be. It offers privacy to patients, especially to women who often don't want to go to healthcare facilities and consult with a doctor. They can do it now much more easily, remotely. So certainly telemedicine has picked up in a big way post-COVID. Even initiatives like tele-ICUs, where you have specialist expertise, which is made available to doctors in remote areas remotely. That is also picking up, and I think it'll pick up more because, of course, we do have a shortage of doctors and specialists in the rural and remote areas. And so technology can at least partially help to start, addressing that expertise gap. And even eventually, we are likely to see a disruption with 5G, which can even allow remote surgery, where it is possible that a health professional could operate on a patient in a different continent through equipment that mimics the health professional's movement simultaneously. So this would, of course, be a huge advancement, a huge leap, but certainly possible with 5G. So we can see this disruption coming in. Next slide. So now I just wanted to focus a little bit on this area of women's health, because I think it's so crucial. And, so I thought it devotes some, deserves some attention. So I'll focus on that for the next few slides. Next slide. So these are some of the key factors for those who are not aware that, just to make the point that women's health is not just reproductive maternal health. And historically, that is how we have looked at women. We have always looked at women as, people who will bear and rear children. And we've looked at their health from that point of view as well. And to say that is not the only way in which we need to look at women's health. Women also face many, many other health challenges, right from chronic diseases, cancers, osteoporosis, mental health issues, and of course, violence, sexual violence. All of those are a whole gamut of issues that we need to look at for women, and we need to not just focus on the reproductive maternal side of things. Next slide. Now, what have been some of our achievements, and where are some of the challenges? So clearly, because we put so much focus on maternal health, we have seen, that has given us dividends. The maternal mortality in India has declined significantly over the years, as you can see here. But next slide. There are state level and even district level variations. So here, of course, I've shown a state level disaggregated picture. But if you go down to the district level, then even within states, you will find, sometimes significant differences between districts. And so that is now where our focus needs to be when it comes to maternal mortality, that we need to really hone in on these gap, areas where the gaps exist and have targeted interventions for these states and districts, because certainly at a national level, we've done fairly well, but we need to address these state level and district level inequities. Next slide. Now, contraception, family planning, another very important area. And by and large, you would see that the indicators are positive. This is from the National Family Health Survey, the 4th and the 5th rounds. And you will see that the overall use of contraception, the demand for family planning, by and large, this has gone up. But there is a problem of contraceptive discontinuation, which has also gone up actually between NFHS 4 and 5. And there is a challenge that much of the family planning, you can say, onus still lies on the woman. So contraception, family planning, much of the onus is still on the woman, and men are still taking very little responsibility. So that is, and that remains a big challenge, because ultimately, whether it's contraception, whether it's family planning, it has to be a shared responsibility between men and women. So that is an area that we need to focus on, that it should not just be the woman's job to take care of this. Next slide. Now, total fertility rates have definitely declined, and this will also tie into something I talk about later, which is aging. So you can see that at the national level, we have reached pretty much what we call the replacement levels, which is, we are at 2 or close to 2 in both the rural as well as the urban areas. In fact, in the urban areas, in NFHS 5, we are much lower than 2, so much lower than the replacement level even. But certainly in the rural areas and at a national level, we are roundabout at 2, so which is the exact replacement level. So fertility rates through all the NFHS rounds, you can see there's a clear story that we have declined. But here as well, there are state level differences. And I'll talk about that when I talk about aging, because this obviously relates to aging as well. Next slide. So these are various indicators, again from NFHS, which pertain to the pregnancy and the postnatal phase. Again, you can see that mostly there is a positive trend. Women are getting the checkups that they are supposed to during the antenatal phase. Also, the coverage of the ICDS program has gone up by and large amongst pregnant women, as well as among breastfeeding women. Institutional deliveries have improved. So there is generally a positive picture on the whole maternal health piece. But as I showed earlier, that there are state level and district level differences, and we have to we have to be able to address those with targeted interventions, and we're trying to do some of that through initiatives like the aspirational districts program, the aspirational blocks program, which Niti is steering, where we are trying to address these disparities which exist between districts and between states. Next slide. Now, this is a very important area when it comes to women's health as well, agency as well as domestic violence. And what we see is that by and large, there has been improvements in certain aspect of women's agency. There's been a significant increase in the ownership of bank accounts, for instance, in the percentage of women now possessing a mobile phone, etc. So I think that has definitely improved. But the violence, especially the intimate partner violence, spousal violence, that remains a very big concern. And the most concerning part is that in the NFHS, we could see a trend, upward trend amongst men with respect to justifying, beating of their wives. At least amongst women, there was a decline, in the percentage of women who justified that violence. But amongst the husbands, it was a small increase, 2%, but nevertheless an increase, where there was a justification for that violence. So I think that is problematic, because that shows attitudes towards women are still problematic. And we have deeply ingrained patriarchal issues that we need to tackle. And of course, as we know, government alone can never do that. You can never have just a government scheme to address such mindsets or deeply ingrained issues. So we need everybody to rally around, right? From civil society to communities themselves, to especially young people, youth, media. Everybody needs to come together. Only then would we be able to tackle these kind of, attitudes and mindsets. Next slide, please. So, a couple of important points here. One is that there is a shift in the healthcare needs, and this is, of course, true for men and women, where we are seeing an epidemiological transition from infectious diseases to non-communicable diseases. And so we are seeing that NCDs, whether it's heart ailments, diabetes, cancers, mental health issues, these are these are now accounting for much more excess mortality, even at younger ages. Previously, the excess mortality at older ages was mainly due to NCDs, but now we are seeing that even at younger ages, NCDs are becoming more important. And interestingly, in India, compared to the rest of the world, if people in rest of the world get a particular cancer at, say, 60 or 70 years of age, in India, interestingly, that is usually at least a decade earlier. So that is a worrying thing, because we have a very young population, and yet many people amongst those are getting affected, even with these serious chronic conditions at much earlier ages than we would expect. So that is a big challenge, both for men and women to handle. But the other point I wanted to make here, which is gender specific, is that we have a gender bias when it comes to healthcare, seeking healthcare. And you can read what's on the slide, but I also wanted to give an anecdote that I work with children suffering from cancer from underprivileged families in my own personal capacity as well. And when I asked, I was at a shelter home with such children and their families, and I could see that it was overwhelmingly boys who had come for treatment from villages. And so I asked the NGO that, why do you have mostly boys? Surely it's not like cancer affects more boys than it affects girls. And they said, no, that's not the case. It's just the case that people don't want to bring, girls for treatment because, they feel, oh, this is a wasted expense. Anyway, I would have to pay for her dowry, or I would have to pay for other expenses, and now she's fallen sick. So it's not worth getting her treated. So there is a huge unfortunate gender bias like that, which still exists. It might be shocking to many of us, but it exists. And people still would rather get a male child treated versus a female child. So this is a gender bias rather than gender differentiated disease infliction. It's not that boys are getting more cancer than girls. It's that we don't want to get as many girls treated. So that is something that the society needs to address, because it's not something that any government can by itself address. The entire society needs to kind of wake up to these issues and say, okay, this is unacceptable, and why is this happening? Next slide, please. So now I'll talk, like I said, a little bit about aging. And the point I'm making here is that it's not too early to talk about aging. We always talk about India as a very young population. We talk of the demographic dividend. We have the largest population of children and young people, which is all true. But aging is also happening. And so simultaneously, we need to also start preparing for that. And that's the point I want to make through a few slides. And then I'll come to my final section on policy. So next slide, please. So as you can see here, the elderly population is expanding at an unprecedented rate. And it is possible that by the middle of the century, it could surpass the children's population in India. So this is a very, very important trend that we need to be aware of, that we might have more elderly than we have children as a percentage of our population by the middle of this century, which is not too far away. Next slide, please. So this is, showing it in a different way, the changing shape of the population pyramid. You can see, right now we have a substantial base, so the younger people, and then you can see how that changes, between 1950, 2019, and then what is projected for 2050. Definitely, it's swollen and it has that bulge in the older age groups. So the share of the elderly is going to go up. Next slide, please. Now, this is interesting, and this also comes back to the fertility slide that I was talking about. Some states are being hit earlier by aging than others. The entire India is not going to go through the demographic transition in one phase. Every state is going to go through at a different stage, because the fertility rates are stabilizing at different rates as well. So, the states with the lower fertility rates and which are getting the early hit of aging, states like Kerala, Tamil Nadu, Himachal, Andhra, and even Punjab, And where states where fertility rates are still on the higher side and are still not stabilized, you can see that they will be hit by aging a bit later. Bihar, UP, Jharkhand, Rajasthan, MP, they will, face aging a little bit later, but it's going to come even to them. So the country is going to be going through this demographic transition, but at different stages, at different pace, across states. It's not going to be a one size fits all. It's not going to be that whole of India is going to experience something all at one go. Next slide. Now, this is an important point, next few slides that I want to make on the feminization of the elderly, as I call it. And I don't think anyone else has so far noticed this trend very much, but I've been doing a lot of the data digging, and I think this is a very important trend to be aware of, is to say that this is the sex ratio you can see of the general population and of the elderly. So the general population is the orange line at the bottom, and this is basically females per 1,000 males. So for the general population, you can see that it is usually we have more males than we have females because the ratio is less than 1,000. But if you look at the elderly, the number is less than 1,000, sorry. But if you look at the elderly line, which is the green line on the top, you can see that we have more females per every 1,000 males. So there is a feminization of the elderly. As we have more elderly people in the population, a larger share of those are going to be women. And so this will have also important consequences when we talk about our health system and the health needs. Next slide, please. And this is then, I'm adding another dimension of vulnerability. This data shows that more than half the 60 plus women in this data you can see have lost their spouses. So if you add the fact that you have mostly women or large number of women in 60 plus, and a large number of them have also lost their partners or their spouses, there is heightened vulnerability. There's going to be heightened issues like loneliness, like depression, even safety. All of that are going to become much more important, and the health system will also have to adjust itself to meet those needs. Next slide. So as I was saying, depressive and anxiety disorders, you can see that they're a major problem in the elderly, especially. Of course, they're a problem in the youth as well, but they're a major problem in the elderly and much more so in females. Again, the red line at the top, you can see that it is the females. There's a clearly higher prevalence of these depressive and anxiety disorders in the elderly females. Next slide. And this is another set of data making the same point. This is from the longitudinal aging study, which was conducted in 2017-18. And this is showing the percentage of older adults screened for positive depressive symptoms. And again, you can see this is giving you different cuts by age group as well as by rural, urban, and male, female. And here again, you'll see that females are on the higher side, at least a few percentage points higher than male in the 60 plus age group. Next slide. So this is how the health system will be impacted by this. We have to develop the doorstep healthcare delivery and home care much more strongly. Right now, there's a few states that have thought about it, and naturally, those would be states like Kerala, which are hit by aging already. But eventually, we all have to think about it. The whole country has to think about it. So doorstep delivery of services, long-term care of patients, home-based care, where you have trained formal caregivers, such as nurses, such as allied health providers, home care aides, and of course, as I spoke earlier on, that your telehealth and digital tools will become very important because, elderly people, you cannot expect that they keep coming all the time to hospitals or to health facilities. It's not even advisable for them. So you will have to do much more of the remote monitoring, continuous monitoring, but you'll also have to invest in the caregiving side of things, the long-term care aspect. And so home health care has a huge potential for growth in India in the coming years, clearly. Next slide. So this is a quick summarization, and then I'll just move on to the policy side of things, just a few slides. On public-private partnership, because I think health is one sector where, government alone especially cannot do it. Private sector has to play a big role, and it can only happen through public-private partnership. I think we do it, reasonably well in some places, in some pieces, but we need to do it much better, and we need to do it at scale. So I think, but there's a lot of opportunities for that. And I'm just highlighting a few here. So large scale screening, as I mentioned, the hospitals in the smaller cities and towns, access to affordable medicines and medical devices, home health care, remote continuous monitoring for chronic conditions, and telehealth, including telemental health. I think the mental health services, as I said, the demand is going to go up significantly. So there's a huge potential for public-private partnerships there as well. Next slide. Yeah, so now I have a few slides on, what is the policy focus, what I think should be the policy focus. So I'll just cover that in the next few slides. Yeah, next slide, please. Yeah, thanks. So now this is important. I think we do need a gendered approach to health policy, and that's why I presented all this data to make that case that we cannot have gender neutral policies. It is a fact that, men and women, certain healthcare needs are different, certain nuances are different, the socio-cultural context, the biases, the patriarchy, the mindset, all of that comes into play. Even when we think of healthcare, normally we don't make that association that, why should an healthcare issue be related to patriarchy, for instance. But as I gave you an example, that it's very much directly related. And so we need a gendered approach to health policy so that we can address the nuanced and differentiated needs of both men and women. Next slide, please. So this is something that I've been pushing for a long time, and we've included it in the Niti Aayog's 3-year action agenda that we published, and we constantly we're making a pitch for it. Hopefully, it will happen one day. And if you see countries like Rwanda, Finland, etc. I mean, Finland is a well-known example of gender equality. The Nordic countries are well-known examples, but Rwanda is a very interesting example. It's a poor country. You don't really expect that they would have done so well on gender equality, but they've done a lot of initiatives. So, if you're interested, you should read up on Rwanda. They always do fairly well in the gender equality indices as well. And one of the things that they've done is that they have what you call a gender monitoring unit, which basically monitors different indicators related to women, how they are progressing, because as you can imagine, as I spoke also, women's health is not the job of any one ministry or department. It is a very multi-sectoral issue. Everybody from health to nutrition to drinking water sanitation to road transport, because maternal health has a huge connection to road transport. A lot of the improvements in maternal health have happened because we have better roads now and people can reach health facilities faster when they need to in an emergency. So it seems like an unlikely connection, but road transport and highways is also connected to women's health. So it's a very multi-sectoral issue, and therefore we need a monitoring unit which can look at indicators, which can look at how different schemes are doing, different legislations are doing, what is working, what is not working, disaggregated state level and sub-state level picture. So I think that is very important. The second function of such a unit would be to research issues that disproportionately affect women, because we need more policy research. We need those startling, hard-hitting statistics and what lies behind those statistics if we are to make a policy case. So for instance, here I've given that suicide is the major cause of death for Indians between 15 to 39 years. You can imagine this is the prime, this is when people are at their prime, the youth. But 71% of these suicides are women. That's overwhelming. 15 to 39 years, 71% of suicides are women. And I've written about this extensively. Now, why is this happening? We have our own theories, we have anecdotes, but we need proper systematic research so that we can go to the decision makers and say, look at this data. This is absolutely startling. And so such a gender monitoring unit can do some of this research, can bring out some of this data on a regular basis, because data, facts make people sit up. That is the reality. If you can tell somebody that this is a big issue, it's affecting millions of people, even the political leaders will sit up and notice. So that is what we need to do. And that is the kind of research we need to come out with. And also, finally, I think mapping the skill availability and employment potential in professions that disproportionately employ women, like nursing. I think we can address so many of our nursing needs, allied health professional needs, if we're able to really connect, women to that kind of training, because women do naturally, gravitate towards a lot of these professions. They do very well also. These are also professions which are very well suited for women. And so we need to map that skill availability and that employment potential as well. So I think these are, some key areas where I believe that a gender monitoring unit, could really impact things very powerfully, especially in the health space of women, but even for women overall. Next slide, please. So I think it's the last 4 slides now, where I'll just quickly go through some of the points that we are focusing on in terms of the policy response. So as I said, there is a huge push on screening for cancers, for common cancers, also osteoporosis, which I've not talked much about, but it is an issue that affects large numbers of women. And maternal health care, the idea is to really address the intra and interstate disparities. That is where our focus is now lying. Malnutrition is a huge issue, not just, from a childbearing perspective, but even for women's overall health. Malnutrition, anemia is a very big issue. So that is something that there's focus on. Elderly, as I said, we have to already start thinking about, and we're doing that. And convergence among ministries, which I also highlighted, that healthcare is a very, very multi-sectoral issue. We can never have just any one ministry which can do justice to it. Next slide. Now, these are some aging specific measures that we are taking, and I believe we need to take more of. Aging will have a difficult impact on the economy, on the overall country, and the vulnerable sections, like I highlighted, feminization of the elderly, a lot of those women who lost their spouses, etc. The vulnerable sections may suffer disproportionately. So we need to have a special focus, especially on comprehensive primary health care for the elderly, including mental health, elderly support groups, because like I said, isolation, loneliness, depression, these are going to be big issues. And then, convergence again, of course, here as well, even with the elderly, it's a very multi-sectoral issue. It's right from health to social justice to women, child, finance. Everybody has a big role to play. So, social security is linked to health as well. So I think here too, we need to really have this kind of multi-sectoral approach to this issue. Next slide. So now these are some more specific areas that we're trying to work on. One is the whole early childhood development, care and education. So far, the focus has mostly been on the 3 to 6 years age group, when it comes to children. But what we are trying to shift is that let's make it 0 to 6, because 0 to 3 is really the first 1,000 days of life. That is really the golden period. The first 1,000 days of life is when most of the brain development, cognitive development, even the foundations of somebody's immunity, nutrition, everything is laid in those first 1,000 days. So we are saying, let's use this Anganwadi platform, let's make it more effective, better, revamp it, and let's provide comprehensive healthcare and education to children in that 0 to 6 age group now, instead of just 3 to 6. The next big window of opportunity is the school health. And school health, where you also have adolescents, it's a huge window of opportunity from a health point of view, screening children for, conditions that they might develop later in life, making them aware, providing them with the right kind of health knowledge, awareness, checking against things like substance abuse. So I think a lot of those foundations are laid in childhood and in adolescence, and therefore those are two very important windows of opportunity that we're trying to capture and capitalize on. And the third one here, as I said, the comprehensive primary health care. We now have the health and wellness centers, or the Ayushman Arogya Mandirs, as they are now called. And we're trying to ensure now that all of them are functional and are actually providing the full package of services that they are meant to. Now that, again, as we know, it's a state level implementation issue, but we're trying to address, whatever gaps are there in terms of human resources, etc. Next slide. And I think it's my last slide, which is that we are making a final decisive endeavor to eliminate both childhood undernutrition as well as anemia amongst women and children. And of course, here, as we know, that this has to be a huge push on behavior change. Of course, we've had the Poshan Abhiyan. The Prime Minister has constantly talked about making it a Jan Andolan. So those are things that we need to do, because we need to change behaviors. We need to change dietary patterns to people making more healthy choices. But we also have to make a more conducive and enabling environment for them to make those healthy choices. So healthy foods also have to be accessible and affordable, and they have to fit into the local diets. So those are very important issues when it comes to nutrition, but also anemia. There's a health side of things, which is test and treat and track. So that is, test, treat, track, that we are doing, that, you try and test large numbers, you screen large numbers, you treat whoever needs that treatment, and then you track, you monitor. So there's a health side of things. There's a big nutrition behavior change side of things. There's, of course, a water sanitation side of things, because, you have to drink clean water, you have to have access to sanitation. And, of course, we've now got much better access to toilets, but the challenge is maintenance. The challenge is regular use of those toilets and that sanitation infrastructure. So it's again a very, very complex issue. But we are trying to make this, kind of decisive endeavor on eliminating both childhood undernutrition as well as anemia. So I think that was my last slide, right? Yeah. Thank you. And I'll be happy to take any questions that I can. I'm sorry if I've taken more time than I was supposed to, but I just thought I'll, put out some of the data. It might be interesting for people. Thank you.
Thank you so much, ma'am, for such an informative session and presentation. And we are really grateful to have you here. So now I would like to invite the chair of the program, Professor Mukul Asherji, for his kind comments on this. Over to you, sir.
Dhanyavad. As we have come to expect from Urvashi Prasad, this presentation had many important insights which are not usually emphasized in health policy and governance discussions. As I had mentioned before, most of the emphasis is on expenditure, but there was no mention of expenditure in the whole insightful presentation that was made. Now, one was the granular way in which we have to look at health. And second, the interconnectedness of health. One of the things that if you have better roads and you can move faster, you get better access to health and health indicators improve. And so looking at this whole manner, integrated manner, is the next insight that came through. A lot of the data are granular, not just overall aggregates as such. And the importance of dispersion of any indicator around the country so that we need state-specific or many district-specific type of health initiatives that was emphasized as well. One area where I would have liked a little more discussion by Urvashi, though it was implicit, is that the health services are being delivered by more or less the same government organizations as before. So what is our strategy for organizational change? Now, one example is that the ESIC, which provides healthcare arrangements for private sector workers, was originally, since independence, under Ministry of Labor. It is still under Ministry of Labor, when it should be in Ministry of Health for more better integrative healthcare. So I think one area that maybe Niti Aayog as well, and the government through Niti Aayog will need to pay more attention to is how to bring about organizational change in those who are delivering healthcare services. Because in many areas, we have been able to make that change and improve performance. But in healthcare, for some reason, that emphasis that is needed has not been as much there. Okay. So once again, there was so much learning, and I think the participants would have gotten a much better appreciation as to how we started in the first session. Healthcare is complex, and this presentation showed us further in different ways how complex the healthcare is. Thank you again, Urvashi.
Thank you so much, sir, and thank you so much, ma'am. So the floor is now open for the questions. The participants can kindly put their questions in the Q&A box, or they can unmute themselves and ask the question. Yes. Ranjan Das Ji, you can ask your question.
Yes, good evening, everyone. It
Good
was a
evening.
wonderful presentation by Dr. Urvashi Prasad from NITI and very immaculately moderated by our chairperson, Professor Mukul. If I am permitted to add a couple of points to whatever has been mentioned already, Professor Ashar particularly mentioned about the workforce, the ESI component. Sir and madam and my colleagues, I would like to share that, sir, the organized workforce of the country is probably just 5 to 7%. The remaining 93%, close to 93% or around that, they are from the unorganized sector. And as of date, we do not have any mechanism through the Ministry of Labor to have addressed their needs. So they are probably being addressed only by the regular routine healthcare services, whatever we have, either from the government sector or other sectors. That's one point. So we need to look into that particular aspect, and we from the All India Institute, being an apex institute working for the government, we are thinking of proposing a program for that particular area for the unorganized sector, who comprises the majority of the workforce of this country. The second point that I wanted to emphasize here is regarding the various manufacturing incentives that we are providing for our startups, and including the various modern sensor devices which can be used for remote sensing the diseases, the diagnostics, the decision making. Not just in this respect, but also the entire gamut of research. So what we are observing, that most of the research that is being conducted in our country is actually a cut, copy and paste of, and a fraction of whatever is being done in other countries, peer countries, as well as the developed nations. So many proposals are coming to us from premier institutions like All India Institutes and various other top-rated medical institutions. And the research proposals that we are getting, they are having Indian PIs or co-PIs who are not actually having much participation or contribution into the research that is being finally accorded and approved by whoever are the competent authorities. So that area also looks a very careful and cautious look. So I would request, since NITI representatives are here, who are the highest level policymakers for the country, that research, until and unless real research takes place within our background, within our institutions, till that time we will not be able to get benefit what is required and what has already been very nicely proposed and is being worked up meticulously at the national and at the sub-national level. So the area of research really looks requires to be looked into very, very cautiously, jointly with the Department of Health Research and the ICMR, jointly with the NITI Aayog. So those were the two comments that I would like to make, and I would leave the floor to our chairperson and the other experts from NITI Aayog and my other colleagues. Thank you for giving me this opportunity.
Thank you so much, sir, for joining and adding your comments. Next, we can take Omkar ji.
Hi, ma'am. Good evening. Yeah. Urvashi ma'am, that was a very insightful presentation, ma'am. We could see a lot of, data, which really needs, a lot of policy changes or new policies that has to be framed to address the upcoming challenges India might face in the future. So my question is on two things, ma'am. One is, first thing is that, as you can see, there is a lot of, emphasis given on NCDs basically in India. Parallelly, I also want to understand, are there any policy interventions that are being done on AMR, ma'am? Because AMR is believed to be one of the biggest, health threat, globally by 2050. So since India is a very densely populated and, anybody can walk to an pharmacy and buy an antibiotic and use them, right? So this is creating a lot of AMR. So just wanted to understand, are there any policy interventions that are coming up, to address this issue? That is one thing. Yeah. Second thing, I work on precision medicine, ma'am, because from the last years I had a company where we are working on. I had the R&D division where we are working on how drugs affect the Indian populations at the end of the day. So what we have observed is that a single drug like statin can't be recommended pan population basically. The same drug, a statin drug which acts on Telangana population is different from Gujarat population. It acts different from the population of the Jammu. So are we creating any policy frameworks to generate such kind of precision data which can be used in the public health at the end of the day? So these are my two queries, ma'am.
Okay,
Yeah.
thank you so much.
Should I answer? Or do you want to take, if there's another question, you can take and then I can answer together.
Sure, ma'am. We can take Gayatri
Yeah.
ma'am's question and then we can continue.
Yeah.
Gayatri ma'am, you can continue.
Thank you, Ms. Tanu. Good evening, everyone. Thank you, Urvashi ma'am, for that very wonderful lecture. And like Mukul sir said, it was a lot of, it really showed how complex our healthcare system is. One of the things that, I in my field work a lot with is data. And I mean, that hasn't come up much in this lecture. And I think that's a whole other minefield that we go into. Two things that I've observed with data is, one is that when it comes to monitoring of how the schemes are running and things like that, it's always mainly based on how much expenditure has happened on that scheme, which actually doesn't tell us much about what really happened on the field, other than say underutilization or no utilization. Is there something in the works on making monitoring and evaluation more process-based? That was one question. And the other question was again related to data. This is on health of school children. I know we have RBSK that goes on, but I am unsure on whether there is any other published data of school children. So for example, Portion Tracker, as we have seen, tracks ECD, early or 0 to 6 years. But I don't know if there's any data available on health of school children. If you could guide me towards something like that, that would be useful too. Thank you.
Okay, so yeah, so I think firstly, yes, I said at the outset, I'm not covering everything today. I mean, you'll have to have me for several hours if you want me to talk about everything. So yes, certain pieces I did not speak about today much. Even in health insurance, for instance, is its own piece. Data is its own piece. Financing, of course, center, state, that is its own piece altogether. So I didn't cover some of those, but I wanted to cover more issues which are not talked about so much, like aging and women's health. And I think these are issues that people don't necessarily talk that much about and that specifically about. So I just picked those. Now, to come to the specific questions, firstly, on the antimicrobial resistance, yes, that is a big policy focus. In fact, we highlighted it even at our G20 presidency. It was one of the major parts of the discussion because, as we know, these are also global issues. These are not just country-specific issues. So at a country level, every ministry, every department which is relevant to antimicrobial resistance, their specific plans of action have been developed, and that whole process has been steered by Dr. Vinod Paul, who is a member at Niti Aayog. So every ministry, every department, because again, you need intersectoral action on this. So there are specific action plans that are being developed, and the work of the ministries and departments will be shaped keeping those in mind. So certainly it is very much there on the policy agenda at the national level, but of course, then we also need to take it to the subnational level, like with everything in India, just the national level never suffices. The next question was on the precision and whether we have policies around that. I think certainly we will develop certain policies. I mean, they will not be very sort of specific at this point because we have to give states their flexibility. We have to allow the field to develop first adequately. But now that we are seeing these kind of developments, we are seeing advancements, we are seeing a critical mass of organizations working in this space. I think certainly that is something that will happen because, like I said, precision medicine, that is the direction that the whole health system is very much going to be taking. But we're still some way away from that, and so we need to think more holistically about it because I think sometimes the immediate answer for any government is that you just come out with a policy or a scheme but I think that has to, before you do that, especially for a cutting edge area, it's very important that you've done your adequate thinking on it, your adequate stakeholder consultations, all of that. So I think that is all work in progress right now. And so, we should see something, but it has to be something thoughtful and we have to be clear, how do we really go about implementing it. On monitoring and evaluation, yes, Niti itself has an attached office, which is called the Development Monitoring and Evaluation Office, where I've also worked for some time. And what we are trying to do there is precisely this, make a shift from just looking at expenditure to looking at outputs and outcomes. And in fact, we have the output outcome monitoring framework, and we put out the data alongside every union budget. If you go and check, you will see the last several years alongside the union budget, there has been an output outcome budget that has been put out, where for at least all or most of the central ministries and departments, we put out data on certain key indicators in terms of how those schemes are working and what have they achieved. It's not perfect, obviously. Any system like this in a country like ours, so complex, large, everything, it's obviously not perfect, but I think it's an important start. And we've taken this output outcome monitoring framework to states. We are training different states on also adopting this at their level. So I think that shift is very much happening. But we also need to fundamentally improve the quality of our data. We need to integrate very fragmented data sets. And that is, my answer to your second question on the school health, that yes, it's different schemes, different programs which have their data sets, but all that needs to be brought together. There's central schemes, there's state schemes. So there is a lot of complexity in a subnational, structure, federal structure like ours. It's bound to be complex. It's not simple, but the effort is towards integration of these fragmented data systems, and the National Data Analytics Platform of Niti. This is exactly what we're trying to do, that makes sense of these fragmented data sets and come up with sector level insights based on whatever data we are pulling in from different sources, but also fundamentally trying to improve the quality of that data, use technology, So a lot of that is also work that we're trying to do. But it's a huge piece, and talking about that, like I said, that's an entirely different thing in itself. But just to say that yes, we're doing that, and we're trying to make the shift certainly from inputs or just money. And that's why today consciously I didn't talk about money, because I think with health, that is the only thing that we end up talking, that we need more money, and we certainly do. I think there's no public health person who'll ever say that we don't need more money for the sector. We certainly do, but both at the central and the state levels, it's important to not just think that the center does it. The state has a huge role to play as well, given that it's predominantly a state subject right now, but we've, certainly making a push even at the central level. So I think money is very important, but today I wanted to say that it's, beyond money. There's so much else that we need to do and we need to look at, and even make better sense of the data that we have. Like the aging data is already available, but I don't see enough researchers, people really talking about it, putting it out there for policy purposes. So I think that is also very important. While you constantly try to improve the quality of data, but whatever data you have, even if it's not 100% perfect, it's important to draw these kind of insights, because I think it makes people sit up and notice that yes, the point you're making is valid. So I think that was the attempt that I was trying to make today through some of this. Yeah, I think I've answered pretty much everything that was asked.
Yeah, thank you so much, ma'am, for
Thanks.
giving such insightful answers and joining us today. Okay, Lakshmi
Thank
KG wants to say something. Okay.
Thank you, Ms. Urvashi. My question is about, can you say a little bit more about the governance related challenges that you foresee when you're speaking about newer plans and ongoing plans that are being made in the health sector? Can you say a little bit about challenges specifically related to governance?
Yeah, I mean, that's a big, broad question. And there's a lot of challenges always, like I said, right from the convergence issue, the whole multi-sectorality of these issues. There's different stakeholders at the central level, at the state level, at the sub-state levels. So I think a lot of the challenges relate to that. And of course, engagement of all the stakeholders. How do we use technology? How do we really reach out to the end beneficiaries, take them on board? So I think those are the kind of challenges, which exist, whether it's a new plan or an old plan. Implementation is the biggest problem and biggest challenge, because we are such a large, complex, diverse country. It's not actually about making the plan. Making the plan is the easy part, but implementing it is where much of our challenges lie. So I think that is where our focus needs to be, and that is why I hesitate to say that we should just come in with a new policy or we should just come in with a new scheme. I think first we need to implement well what we have, and I think that is very important. So that's where a lot of the focus is going on. How do we better implement a lot of the policies and plans and programs that we have on paper?
Okay, thank you so much, ma'am, and thank you so much, Lakshmi ji. Ranjan sir, you can unmute yourself.
Yes, okay. Thank you for this opportunity. Am I unmuted? I think I am unmuted. I think I am audible to all. Okay, thank you. So to whatever has been mentioned by Dr. Urvashi, first I will speak on the AMR issue, antimicrobial resistance issue, that was asked by one of our participants. So in this regard, as has been very well mentioned, that NITI Aayog is taking the lead, and the support is coming from the NCDC, that is the National Center for Disease Control, under the Ministry of Health and Family Welfare. And they are trying to coming up with a policy, and also they are taking the program to the states and the subnational level. So there we are implementing it, in consultation and in collaboration with the various states and union territories. But one of the major challenges that we are facing is that antimicrobials are not just used for the human sector alone. They are also being used quite extensively for the animal sector also. The poultry, the animal husbandry, the fisheries, all these sectors are using antimicrobials in huge quantities. And finally, since we are at the higher end of the food chain, all those antimicrobials are finally entering our bodies, and we are also exposed to antimicrobial resistance through that channel also. They are also being used for the plants also, as is being now pointed out through various literature. So the one thing that the government of India, the 29 ministries and departments are together trying to put up is the One Health mission. So this One Health mission is a very important aspect, and that will be giving us some footage on controlling this antimicrobial resistance. So that was one important point. And this One Health mission is also being coordinated in a very nice manner with various ministries, the animal husbandry, the forestry, the environment ministry, of course, the human health, and many other ministries. Coming to the second point that was asked regarding the funding and the expenditure, and very nicely, Dr. Urvashi has mentioned the output and outcome and output framework, which is being taken care of by various ministries and departments. To that, I would like to add that this is, again, as has already been pointed out very clearly by Dr. Urvashi, that this is our challenges are multi-sectoral, technology related, implementation issues. So one of the key factors or key effects through which we are trying to address this issue is the formulation of the KPIs, key performance indicators. Now, these key performance indicators are already, they are shared with the various stakeholders at various levels through various boards, online, offline. The thing that I was trying to convey to my colleagues here is that the KPI is an issue. It is requires addressing right from the grassroots up to the topmost level. I will give you an example of how we are trying to do it for our own institution, the APEX, All India Institute of Hygiene and Public Health, the Port Health at Kolkata, the Airport Health. But we have got various institutions, beginning from the health and wellness centers, which is at the grassroots level, with our Anganwadi workers, with our ANMs or health workers. Above them, we have got the medical officers and the PHCs, above them, the rural health training units, the urban health training units, and above them, of course, the entire APEX institution. So we are catering to...
Ranjanji, thank you so much for your comments, and I'm really sorry to be interrupting you, but we have our next speaker here already, and we will be a little
Can I
short
sum
on
up in
time.
half 30 seconds? Can I get 30 seconds to sum up?
Sure, you can take 30 seconds.
Okay. So KPIs have to be done for 4 or 5 major key indicators for each level, beginning from the lowest to the highest. And that will help us in understanding what we are doing and how effectively we are doing. With that, I will end. Thank you so much.
Thank you so much, sir, for joining us, and thank you so much, Urvashi ma'am, for answering the questions. Let's move forward. Now it's my honor to invite Professor Pradeep K. Panda ji, Professor and Dean, School of Public Health, Asian Institute of Public Health, University, Bhubaneswar, for the session on the role of Ayush approach in India's healthcare. We welcome you, sir.
Thank you. Thank you for having me. I've shared the PPT with you. Can you please share?
Yes, sir, yes.
Next one, please. So I'll talk about the role of Ayush approach in India's healthcare. So this is the content of my presentation. I'll briefly talk about the significance of Ayush in India's healthcare landscape, then policy development in Ayush, then benefit of Ayush in public health, and provide a few case studies, human resources for health, Ayush infrastructure, service availability in the Indian public health system, Ayush in the disease burden and treatment realm, Ayush manufacturing and products. Finally, I'll talk about some of the challenges, opportunities, some recent milestone and conclusion. So let me start with the significance of Ayush in the India's healthcare landscape. So first I will talk about some of the robust programs in the Ayush sector to strengthen the Ayush system as a whole. For example, Ayurvidya for promotion of healthy lifestyle through Ayush for school children. Second, Supraja, Ayush for maternal and neonatal intervention. Biomitra, which is Ayush-based geriatric program, prevention and management of osteoarthritis and other musculoskeletal disorders, and Ayush mobile medical units. Next. So some of the other significance, as you know, Ayush emphasizes preventive healthcare, integrating mental, physical, and spiritual well-being. It is recognized by the National Health Policy of 2017 as a vital part of India's health sector. It provides accessible healthcare solutions in rural areas with over 8,000 Ayush facilities nationwide, integrated into national health campaigns to combat non-communicable diseases and lifestyle disorders, included in national health surveys to analyze its impact on health metrics. It is supported by initiatives like establishment of the Ministry of Ayush and targeted development programs. The Ayush manufacturing sector has witnessed an exponential rise of 6 times in 7 years, from $2.85 billion in 2014 to $18.1 billion in 2020. The study conducted by Research and Information System in developing country. And the market size of Indian Ayush industry as a whole has grown by 17% during 2014 to 2020. So next I will focus about some of the policy development in Ayush, starting from National Rural Health Mission to National Ayush Mission. The policy frameworks and NRHM. So the NRHM objective in terms of Ayush, that integrate Ayush to extend healthcare reach and improve service efficacy. Then co-location strategy. Ayush facilities are integrated within primary health center, community health center, and district hospitals as part of NRHM. Then National Health Policy 2017 promotes Ayush integration to strengthen public health care. Then Ayush Mission launched to focus on the development of education and research in traditional medicines. Then Ministry of Ayush was established in 2014, dedicated to enhancing Ayush healthcare services. Increased funding, significant increase in government funding for Ayush under NRHM to support infrastructure and training. Accessibility impact. Ayush expands health service access, particularly in rural and underserved areas. Treatment diversity. It provides diverse and culturally relevant treatment options within the healthcare system. Preventive care focus. Ayush emphasizes cost-effective preventive care, reducing the burden on secondary care facilities, and also Ayush has a global recognition, who supports the integration of traditional medicine into national health systems, recognizing its global efficacy. Then Ayush has been integrated into NRHM to leverage traditional medical knowledge and practices in enhancing the health services framework. It utilizes Ayush practitioners and therapies to supplement and enhance the reach of healthcare services, especially in underserved and rural areas. Ayush practitioners are trained to collaborate with allopathic doctors, aiming to provide a complementary treatment approach that increases the overall effectiveness of healthcare delivery. It employs preventive healthcare measures inherent in Ayush practices to reduce the burden of disease, particularly chronic and lifestyle-related diseases. It utilizes cost-effective Ayush treatments to reduce the overall expenditure on health by focusing on prevention and less expensive, locally available remedies. National Medicinal Plant Scheme. The National Medicinal Plant Scheme was proposed to merge with the Banaspati Bhan scheme started by the Department of Family Welfare under RCH1, aiming to cover 30,000 hectares with herbal gardens in 10 states. Then Ayush integration. Ayush facilities have been integrated under the same roof as PSC and CSCs and district hospital as part of NRHM strategy. The Ayush workforce was arranged either by relocating them from existing dispensaries without buildings or by hiring them as contractual staff with NRHM funds. Medications, related equipment, and infrastructure facilities were supported through the centrally sponsored scheme of hospitals and dispensaries, which received positive responses from states in the 10th five-year plan. Continuing with Ayush integration, some of the statistics during the NRHM, and when the National Ayush Mission started in 2014, the baseline scenario at that time, by April 31st, 2014, Ayush facilities had been co-located with 331 district hospitals, so covering about 44.3% of the district hospital, 1,885 community health centers, so comprising 36.3% of the total CSC, and 8,461 primary health centers, comprising 34.6% of all PSCs. So 1,933 Ayush doctors and 5,419 Ayush paramedics had been appointed contractually. Uttar Pradesh had the highest number of Ayush doctor appointments, 1,829, followed by Bihar, 1,384, and Odisha, 1,316. Ayush facilities serve approximately 26.1 lakh people via the district hospital, 4.6 lakhs via community health centers, and 1 lakh people via primary health centers. Then states and Ayush integration, Arunachal Pradesh, Delhi, Goa, Madhya Pradesh, West Bengal, and Daman-Diu had no contractual appointments of Ayush doctors. In many states, Ayush doctors have undergone skilled attendance and birth and related training to get equipped with the skills required to handle minor surgical and obstetric emergencies with the use of certain allopathic medications, but the legal issues only have not been dealt with properly. Then Ministry of Ayush, Government of India launched the National Ayush Mission, NAM, which is a centrally sponsored scheme in financial year 2014-15 for implementation through the states and union territory on 29 September 2014. So the goal of the National Ayush Mission is to promote cost-effective Ayush services, strengthen educational systems, enforce quality control, and ensure sustainable raw material supply. If we look at the financial outlay, the budget allocation of National Ayush Mission has enhanced gradually from rupees 75.28 crore in 2014-15 to rupees 1,200 crore in 2023-24. Then mainstreaming Ayush, objectives and implementation. So integrate Ayush services at existing allopathic health centers to provide complementary treatment options, train Ayush and allopathic practitioners to collaborate and provide integrated care, enact policies that support the registration, standardizations, and quality control of Ayush medicines and therapies, launch campaigns to educate the public on the benefit of Ayush practices and how they complement modern medicine, allocate specific budgets within public health financing to support the infrastructure, training, and research needs of Ayush. Then, what is the outcome in terms of infrastructure, reach, and healthcare integration? Latest data available. So currently, there are 7,71,468 registered Ayush practitioners nationwide, 550 teaching institutes, 170 postgraduate institutes, 3,639 hospitals, and 26,405 dispensaries, 8,667 drug manufacturing units. Ayush services are integrated into 506 district hospitals, 374 sub-district hospitals, 2,871 community health centers, and 8,995 primary health centers. So there are currently 15,649 practitioners for RBSK under National Child Health Program and 12,263 practitioners providing general health services. 3.1 crore wellness sessions, including yoga, conducted under Ayushman Arogya Mandirs. Earlier, it was known as Ayushman Bharat Health and Wellness Center. It is renamed recently as Ayushman Arogya Mandirs. 13 states, including Karnataka, Maharashtra, and Tamil Nadu, allow Ayush practitioner to practice allopathy in emergencies. So what are the policies and healthcare integration? Envisages integration of Ayush in mainstream healthcare, supported by the National Health Policy 2017, enhancing Ayush hospitals and dispensaries, setting up of 50-bedded integrated Ayush hospitals, co-location of Ayush facilities at various levels of public health infrastructure to increase the access, improvement in the quality of education and Ayush drugs, and strengthening pharmacies and drug testing laboratories, focused on addressing the community health issues through Ayush methods. Then Ayush Gram, it promotes Ayush lifestyle in selected villages for blood, and school health program. It addresses health needs of school children via Ayush services, including yoga. Then, what are the benefits of Ayush in public health? So I'll provide the state-wise scenario and few case studies. So these are the benefits of Ayush in public health. First one is holistic care. Ayush promotes a holistic approach to health, emphasizing prevention, wellness, and treatment of diseases through natural and traditional methods. Second, accessibility. By integrating Ayush with mainstream health services, healthcare is made more accessible, especially in underserved and rural areas. Then next, cost effectiveness. Ayush treatments are often less expensive than conventional medicine and use locally available resources, reducing the cost of healthcare. Then next, reduce side effects, another benefit. Herbal medicines and natural therapies typically have fewer side effects, making them a preferable option for long-term wellness and care. And finally, cultural relevance. Ayush practices are culturally aligned with the beliefs and traditions of various communities, ensuring better acceptance and adherence to treatment. Then analysis of state PIPs. If you see, states show diverse levels of integration from fully integrated systems in Kerala and Tamil Nadu to nascent stages in other states. Karnataka and Maharashtra have allocated significant portions of their NRHM budgets to develop Ayush services. Rajasthan and Gujarat have introduced innovative Ayush practices in public health programs, especially in rural and tribal areas. Kerala leveraged its strong tradition of Ayurveda, integrated Ayush in mainstream hospitals and public health campaigns. Uttar Pradesh focused on training of Ayush practitioners in modern medical practices to serve in primary health centers. Northeastern states utilized local traditions and practices, integrating them with Ayush to cater. Next. Then I'll provide 3 case studies briefly. Case study 1, Ayurvedic intervention in anemia control in Madhya Pradesh. So background, anemia is a prevalent issue in rural Madhya Pradesh, affecting a large number of women and children. Intervention, it was launched in 2017. The program involved administering Dhatri Lavwa, an Ayurvedic preparation to women and children diagnosed with mild to moderate anemia. The intervention included regular health camps for screening and follow-up, combined with dietary recommendations based on Ayurvedic principles. So what is the outcome? Over a 2-year period, the intervention reached approximately 5,000 women and children. Post-intervention assessment showed a 60% reduction in mild to moderate anemia cases among the participants. It also increased awareness and acceptance of Ayurvedic dietary practices and supplements. So case study number 2, yoga-based mental wellness program in rural Karnataka. Background, mental health issues are often underreported and undertreated in rural India due to stigma and lack of access to mental health services. So the intervention, it initiated in 2015. This community-based program offered free yoga classes focusing on stress relief and mental wellness. Sessions were held thrice weekly in community centers and included breathing exercises, meditation, and yoga asanas tailored to reduce anxiety and depression. So what is the outcome of this intervention? The program directly benefited over 3,000 rural residents within 3 years. Participants reported a 40% improvement in common mental health symptoms such as anxiety and stress. The program also saw a 30% increase in community engagement activities, indicating a positive social impact. So let me move to case study number 3, homeopathy for epidemic control in Kerala. Background, Kerala faces periodic outbreaks of viral fevers and vector-borne diseases, especially during the monsoon season. So what is the intervention? The homeopathy for healthy monsoon campaign was launched statewide in 2018 to preemptively manage the spike in monsoon-related illness. Homeopathic medicines believed to boost immunity against common monsoon ailments were distributed free of cost at public health centers and through mobile health units. So what is the outcome? Approximately 1.2 million doses of homeopathic preventive medicines were distributed during the 2018 monsoon season. There was a reported 50% decrease in cases of dengue and chikungunya during the campaign period compared to previous years. The program enhanced community trust and participation in public health initiatives. Let me focus on human resources for health, the Ayush landscape. Education and training in Ayush. Over 500 colleges across India offer degrees in Ayurveda, yoga and naturopathy, Unani, Siddha and homeopathy, accredited by the Central Council of Indian Medicine and the Central Council of Homeopathy, like All India Institute of Ayurveda and National Institute of Homeopathy. Courses range from bachelor's degree like BAMS to BHMS to MD and PhD programs in various Ayush disciplines. Many Ayush colleges are attached to hospitals where students receive practical training and exposure to patient care in a real-world setting. Then the Institute of Teaching and Research in Ayurveda had been conferred the status of an institution of national importance by an Act of Parliament in 2020. 3 state-of-the-art satellite centers of the National Institute of Ayush at Panjim, Goa, All India Institute of Ayurveda in Goa, and Satellite Institute in New Delhi, National Institute of Unani Medicine in Ghaziabad, with Satellite Institute in Bengaluru, and National Institute of Homeopathy in Delhi with the Satellite Institute in Kolkata. So initiatives under research database and library in Ayush, the traditional knowledge digital library, Ayush research portal, Dhara, current health literature awareness services, research and management information system, Grantha Samukaya, and Ayush Sanjeevani app. So there is a comprehensive database on research study. And this is system-wise registered practitioners for 1 crore population in India during 2011 to 2022. As you can see, Ayurveda is the predominant one. And in 2011, so number of Ayurveda practitioners were 3,562, and it reduced to 2,521, 2022. Okay, improvement is better. Second, is coming homeopathy. So in 2011, it was 1861 practitioners per 1 crore population, and it reduced, it increased to 2,336. So performance is somewhat not impressive. And if you go by that, the third one will be Unani, and so on. Next, Ayush infrastructure. So growth in Ayush hospitals from 2011 to 2022. Here also, as you can see, Ayurveda, the number of Ayush hospitals has increased from 2,420 in 2011 to 2,992 in 2022. And Unani, Siddha, homeopathy, etc., that varies between 200 to about 270 during 2011, and not much change. There is a slight increase in every case, but not much change in 2022. Then system-wise, number of dispensaries in India during 2011 to 2022. So as you can see, for the Ayurveda dispensaries, so there is a huge increase from 15,017 in 2011 to 25,280 in 2022. And for homeopathy, the increase of number of dispensaries is from 7,049 in 2011 to 9,031 in 2022. So there is a small increase in other system of medicine like Siddha and Unani. Then services available in the Indian public health system. So this is a summary of healthcare facilities under Ayush. So it gives the number of hospitals. This is the 2022 data. Then number of beds and dispensaries and the registered practitioner and admission capacity, PG colleges and etc. There has been a substantial growth in numbers. Next. Then percentage distribution of Ayush dispensaries in India as on April 2022. As you can see, some of the states, so they have a higher proportion of dispensaries as compared to other states. For example, Karnataka 20.9%, then Rajasthan 11.2%, Uttar Pradesh 10.3%, West Bengal 7.3%, and then Kerala 5.9%, Madhya Pradesh 4.8%, and all other states they have varies from about 2% to 4%. Then, for the first time, the National Sample Survey, in its 79th round, conducted a comprehensive survey on Ayush, and the results are just out. So, survey on Ayush 2022-23. So, I'll provide some of the data on the treatment real. Percentage of persons age 15 years and older who are aware of Ayush. If you see the all India level, okay, the awareness is about 95 to 96%, and hardly there is any rural and urban difference. If you look at rural India, awareness level about Ayush varies from 87% to 99% for all states and union territories, except for Arunachal Pradesh, where it is 77%. Urban India, more than 86% are aware about Ayush across all states and union territories. And awareness level about Ayush is similar across gender. So there are no gender differences in the awareness regarding Ayush. Then percentage of households with at least one member having awareness and knowledge about the use of medicinal plants, home remedies, local health tradition, LST, and folk medicines. So awareness of medicinal plants, there is no difference between rural and urban area. And awareness of home remedies also, there is no difference between rural and urban areas. It is about 79 to 80% for both. Awareness about medicinal plants and awareness of home remedies. As regards awareness of local health tradition and folk remedies, it is the percentage who are aware is less. No difference in rural and urban areas. It is about 24%. Any of the above. Okay. Medicinal plant or home remedies or LST or folk medicine. Again, no difference between rural and urban areas. It is about 85 to 86%. Among the states, maximum percentage of households with awareness and knowledge, Gujarat in the rural sector and Himachal Pradesh in the urban sector. Then next, percentage of persons who have used Ayush system of medicine for prevention or treatment of ailments during the last 365 days. So if you look at the all India level and compare rural and urban areas, the more people have used the Ayush system, 52.9% as compared to the rural area, 46.3%. In the rural area, as well as urban area, females are using more Ayush system of medicine for prevention or treatment of ailments as compared to the males. So in the rural areas, it is 48.8% for female and 43.9% for male. Urban India, 55.4% for female and 50.5% for males. Among all states, highest percentage use is by Himachal Pradesh and lowest percentage use is by Goa. Then percentage of persons who have used Ayush by types of use, purpose. So if you see clearly, both in case of rural India and urban India, the purpose of use is prevention, rejuvenation. 45% in rural India and 48% in urban India. For therapeutic or curative care, it is 28% in rural India and 26% in urban India. Both rejuvenation and therapeutic, prevention and curative, it is 20% in rural India and 19% in urban. So basically, prevention is the most common both in rural and urban area for using Ayush. Then percentage of persons who have used Ayush system of medicine for prevention or treatment of ailments during last 365 days. Here we are talking of the different systems of medicine. So as you can see, in case of the Ayurveda is the most prevalent system of use of medicine. In rural India, it is 40.5%. In the urban India, it is 45.5%. And any system of medicine, if you take, it is 46.3% rural India and 52.9% in urban India. A substantial section of population is using Ayush system of medicine for prevention or treatment of ailments. And among the systems of Ayush, Ayurveda is the most commonly used system by people across rural and urban India for treatment. Homeopathy has been used by the majority of people in West Bengal who have used Ayush for treatment. So this West Bengal stands out for homeopathy. Then average expenditure per person in rupees for Ayush treatment. If you look at the rural India, for Ayurveda, the average expenditure per person is 394 rupees. And others, other than Ayurveda, other system of medicine, it is much higher, 622 rupees. If you take any system of medicine, then it is 472 rupees per person per year. Urban India, again, Ayurveda is much higher. The average expenditure per person is 499. Other systems of medicine is 592 rupees. And any of the systems of medicine is 574. So in urban area, basically, Ayurveda, the average expenditure is much higher, as well as any expenditure. So now, also NSSO covered what are the reasons for using Ayush system of medicine among the households who have used Ayush during the last 365 days. So these are the responses. 7 out of 10 households believe that Ayush medicines are effective. 6 out of 10 households have faith or believe in Ayush. 5 out of 10 households believe side effects are negligible. 4 out of 10 households used Ayush because of one of the 3 reasons: satisfying previous experience, or raw materials are easily available, or it was well known to local people. 3 out of 10 households used Ayush because of one of the 3 reasons: tradition or culture of using Ayush, the fact that Ayush strengthens and revitalizes body, and Ayush medicines are inexpensive. And finally, 2 out of 10 households used Ayush because of availability of individualized personal care in Ayush, or overall well-being or complete care. Then practice of yoga in around 1.1 crore households in rural India and around 1.4 crore households in urban India, at least one member of the households is found to practice yoga regularly. Among the households with at least one member practicing yoga regularly, these are some of the indicators. About 81 lakhs households in rural India, that is 74%, and around 1.1 crore households in urban India, that is 79%, practice pranayama. About 70 lakhs households in rural India, 64%, and around 90 lakhs households in urban India, again 64%, practice asana. And about 54 lakhs households in rural India, 49%, and around 76 lakh households in urban India, 54%, practice meditation. Then there are different schemes under Ayush system of medicine, like Ayurgyan scheme launched by the Ministry of Ayush. The Ayurgyan scheme aims to promote excellence in education, research, and practice in the field of Ayush. Then CME in Ayush, the 11th plan initiated ongoing continuing medical education, CME system, to reach as many Ayush teachers, physicians, paramedics, and other personnel. Then Ayush Swasthya Yojana, a comprehensive health initiative designed to leverage the strength of Ayush systems to support the universal health coverage agenda in India. Then Ayush Aushadhi Gunna Tevam, then Uttapadan Samardhan Yojana, then scheme for conservation, development, and sustainable management. Then contribution of Ayush to modern medicine and research, chronic disease management, Ayush 82 and Ayurvedic formulation has shown promise in clinical trials for managing diabetes by reducing blood sugar levels naturally, infectious disease control, research on neem and its application in treating infections, and as a potential antiviral agent against influenza and other viral infections, mental health enhancement, integration of yoga and meditation in routine clinical practice globally for managing stress, anxiety, and enhancing overall mental well-being, preventive health care. The concept of dinacharya means daily regimen and ritucharya, seasonal regimen in Ayurveda promotes dietary and lifestyle adjustment to prevent diseases, maintain health. Drug development and innovation, development of Ayush Quath formulation for boosting immunity. Trials during the COVID-19 pandemic indicated its effectiveness in enhancing innate immunity. Future trends and potential expansion in Ayush practices, pilot projects in several Indian states where Ayush methods are used as the first line of treatment for non-critical ailments, development of artificial intelligence applications that can recommend personalized Ayurvedic diets and lifestyle adjustments, opening Ayush therapy centers in Europe and North America that adhere to local healthcare regulations, government-funded initiatives to support organic cultivation of high-demand herbs like ashwagandha and turmeric in partnership with local farming communities, the Indian government's initiative to include Ayush services under the Ayushman Bharat health insurance schemes, launch of globally certified organic skincare lines based on Ayurvedic principles, collaboration with global wellness influencers to endorse Ayush-based wellness programs, corporate-funded scholarship programs for students in developing countries to study Ayush courses in India. Then Ayush manufacturing and products. So drug manufacturing units in Ayush scheme, as you can see here, there are 8,705 manufacturing units as of 2022 who are engaged in manufacturing the Ayush drugs. The substantial majority, as one could expect, 7,463 manufacturing units are engaged in manufacturing of Ayurvedic drugs. Whereas Unani, Siddha, and homeopathy, they have a small number of manufacturing units. And there is no change over time from 2011 to 22. Next. Then Ayush Aushadhi, that AOGUSY of Ministry of Ayush has been initiated for augmenting quality of Ayush drugs during the 15th finance cycle, that is 2021-22 to 2025-26. Then Ayurveda Ahar, Ministry of Ayush has taken an initiative to bring a new category of the food named Ayurveda Ahar under the ambit of FSSR for spreading the goodness of Ayurveda among masses. Then Ayush Startups and Incubation Center to promote entrepreneurship, leveraging the academic knowledge. All India Institute of Ayurveda has set up an incubation and innovation center in its campus to nucleate a cluster of new age ventures. Then there are some regulatory reforms, establishment of Pharmacopoeia Commission for India, Medicine and Homeopathy. PM widely quoted talks about Ayurveda in 2015. Ayurveda is no more an option, but forms a fundamental pillar of the country's national health policy and health interventions. National Ayush Mission, NABH accreditation, Ayush Health and Wellness Center, approval for upgradation of a total of 12,500 health facilities at Ayush Health and Wellness Center, and it has been approved for 35 states and union territories. However, the central government share of rupees 714.97 crore has been released for 10,289 Ayush Health and Wellness Center in the states as per the Department of Expenditure guidelines. Insurance coverage has also been provided for Ayush treatment. 27 companies are offering health insurance policies for Ayush treatment. Then what are some of the challenges? The first one is scientific validation. One of the significant hurdles is the lack of robust clinical trials to substantiate the efficacy claims of various Ayush treatments. Second challenge, standardization issues. Difficulty in standardizing manufacturing processes and quality control for herbal medicines due to the natural variability of ingredients. Third challenge, regulatory and legal barriers. Varying international regulations regarding the practice and approval of traditional medicines can hinder the global expansion of Ayush. Another challenge, integration with conventional medicine, resistance from practitioners of conventional medicine and skepticism among the general public about the effectiveness of traditional practices. And finally, resource education challenge, insufficient funding and resource dedicated to research and infrastructure development in the Ayush sector. Then, next, what are some of the opportunities? Rising global interest in holistic and natural health. Increased consumer interest worldwide in natural and non-invasive treatments presents a significant opportunity for Ayush. Another opportunity is technological innovations. The use of technology in diagnostics, telemedicine, and personalized medicine offers new avenues for integrating Ayush practices into mainstream healthcare. Another opportunity, public health integration. Opportunities to integrate Ayush more deeply into public health initiatives, particularly in areas like mental health, geriatrics, and palliative care. Educational collaborations. Another opportunity, establishing more partnerships with international universities and institutions to foster global education and training in Ayush disciplines. Then government initiatives. Support from the Indian government, such as the establishment of the Ministry of Ayush and the inclusion of Ayush under Ayushman Bharat scheme, boost the credibility and funding for Ayush practices. Next, I will focus on some of the recent significant milestones. What is going on in the Ayush sector? Inauguration of Chintan Shibir provided a roadmap for Ayush future, focusing on digital health. First, Shanghai Cooperation Organization Conference generated trade interest of 590 crore rupees, highlighting Ayush growing significance in international markets. Dedicated vertical of Ayush in BIS, Bureau of Indian Standard, 7 Ayush-related Indian standards published, and 53 are in the process of development and publication. Advanced R&D through Ayush-based fundamentals, Institute of Genomics and Integrative Biology, CSIR organization, relation of Ayurveda Prakriti is made with genomic sequence, a landmark study towards personalized preventive and predictive medicine, and also from promising outcomes on gut microbiota. Ministry of Home Affairs notified Ayush visa category AY for foreign nationals for Ayush treatment for the promotion of medical value travel. Ayush ICMR Advanced Center for Integrative Health Research at 4 All India Institute of Medical Sciences, focusing on gastrointestinal disorders, women and child health, geriatric health, and cancer care. IUTech IIT Jodhpur, first of its kind, artificial intelligence-driven integrative framework for population and individual risk stratification and early actionable precision health interventions. Then India Public Health Standards for Ayush Healthcare Facilities. Then STG, Standard Treatment Guidelines and ICT codes. Then multicentric clinical trials for anemia. These are some of the recent significant milestones in the Ayush sector. Finally, to conclude, holistic health model. Ayush promotes a holistic approach to health that includes physical, mental, and spiritual well-being, significantly contributing to India's healthcare system. Cultural heritage. Ayush is deeply rooted in India's rich cultural heritage, offering traditional methods of healing that have been practiced for thousands of years. Healthcare accessibility. By integrating Ayush with mainstream healthcare services, it has enhanced access to health services, especially in rural and underserved areas where modern healthcare facilities are sparse. Preventive healthcare. Ayush emphasis on prevention through lifestyle and diet aligns with global shift towards preventive healthcare practices, reducing the overall healthcare burden. Then global reach. Internationally, Ayush is paving the way for alternative medicine on the global stage with increasing acceptance and integration into health systems around the world. Thank you very much.
Thank you so much, sir, for such an informative session and for such a comprehensive presentation as well. We are really grateful to have you here, sir. The floor is now open for the questions. I would like to encourage the participants to put the questions in the Q&A box so that we can take all of them together.
Okay, meanwhile, we can have Professor Asher's remarks. Mukul sir?
Yes.
Yes, sir.
Only somebody with a thorough expertise in Ayush, like Pradeep K. Panda, it was a wonderful presentation, very informative. One point, when we do research on Ayush and so on, we should make sure that we are patenting our research output. Otherwise, somebody else may get the benefit of our research. So Ayush should be liaising, integrating with our patent process as well.
Agreed. Thank you so much for that input. Patenting is very important.
Thank you so much, sir. We have got one question. In past 10 years, there is substantial growth in Ayush, especially Ayurveda. Can we say today is Ayurveda is streamlined, and what are present challenges in next 10 years?
So as I spoke about some of the challenges in my presentation, for example, standardization, that is very important. Then the standard treatment guidelines for different Ayurvedic products. that need to be actually streamlined. Then international classification of disease, ICD codes, that has to be chalked out. So all these are actually different challenges. So if we do scientific and robust research, more clinical trials, many more good products through standardization, I think the next 10 years also will be good for Ayurveda, and it is likely to emerge as a very important Ayush system of medicine.
Yeah, thank you so much, sir, for answering. And thank you for, we have got one more question. So somebody is asking that you made a point that lack of scientific validity and standardization possess a challenge for Ayush. In fact, this point contradicts many other aspects of the presentation. Could you please say more about this?
Yeah, what I was trying to say is that in general, that is the main issue with Ayush system of medicine. But government is actually in recent years, last 2 years, is doing a lot to standardize putting the protocols, then standardization. As I mentioned in one of my slides, there are many important things the government is doing now. So it will reach, so there is no contradiction. It will actually pay dividend in the future. We are doing better and better. Still, lot more work to do. So this is a huge issue, standardization, but government is actually doing a lot, and that will pay dividend in the future to come. Is that have I responded to your question?
Yeah.
If I am
And
permitted to add,
Okay.
Chairperson and Tanu,
yes, sir,
I
yes,
am
if I
able to
can
hear.
speak.
Please go ahead.
Okay, thank you very much. Professor Panda has really made a wonderful presentation, and we are really enlightened and thankful. Already the point has been raised, and you have already mentioned that the research methodology is required to be strengthened. And we have it has come to our knowledge and attention that as per just like we have our NMC, as per the respective commission for Ayush, there also it has been made mandatory that research methodology training is a very essential component of the faculty as well as UG and PG teaching curriculums.
Absolutely.
And in that regard, I am very happy to share, sir, that All India Institute is collaborating with various Ayush medical colleges in West Bengal, and we are collaborating for building up the research methodology skills both of the faculty as well as the postgraduates. So
Okay.
that will certainly take one step forward our research and including the validation of the various issues, including the processes, research processes. The second
Absolutely.
point that thank you. The second point that I wanted to just share with each one of you here is that as institutions, as governmental agencies, most of the agencies and institutions are observing and celebrating the International Day of the Yoga, and this was the 10th such edition, and whereby we have been able to communicate to the community as well as the worldwide that this International Day of the Yoga teaches the population, the children, the various age groups, the benefits of yoga and meditation also. So we also did large scale functions, programs on this, but we want to take it further. We want to bring it as a part of our lifestyle. And to begin with, we are planning that half an hour to 40-minute sessions we will do every alternate day, at least 3 days of the week for both our students, PGTs, as well as for our employees. They will be given staggered hours so they can come at their own convenience without disturbing the office functioning. So for 30 minutes, they can practice yogic exercises, including meditations, 30 to 40 minutes at their convenient times without hampering government work. So this was one of our strategies, and we will put it to practice very shortly, sir.
Yeah,
So
Excellent
thank you so much,
initiative.
sir.
Very nice. Yeah.
so
Thank you
that
so
was
much,
one
sir.
small
Great.
comment from. Thank you.
So we can take one last question and then we move forward. Have other countries integrated local traditional health system with allopathic systems? What are their challenges? Are they similar to Ayush?
Actually, I don't have the data with me precisely, but many countries have actually they have implemented the traditional system of medicine. Actually, I know one country, for example, Bhutan. It is widely actually used. Sri Lanka, it is widely used. Many other countries are there, but I don't have the data. But because it is also reflected about the huge amount of export of Ayurvedic product to many countries in the world.
Yes, sir. Thank you so much, sir, for joining us today and taking out your time and giving such an informative session. Now, I would like to ask Mukul, sir, whether he would like to briefly continue with his PPT or we can take it in the next session. So,
Yes, are you asking me?
yes, sir. Would you like to take your PPTs briefly or we can take it in the next session?
Next session. I think
Okay. Thank you
we
so
have
much, sir.
Already 9.
Yeah. Thank you so
Okay.
much, Pradeep, sir and Mukul, sir. Now we'll continue.
Thank you, Professor
Okay.
Asher, and all the participants.
Thank you.
Thank you so much.
Professor.
Okay.
This was
Thank
wonderful.
you.
So, as we come to the end of day 2 of Health Sector Management and Governance, an Indian Perspective, an online national summer school program, a 1-month immersive online certificate training course, I, Tanu Paliwal, researcher, IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of IMPRI, Center for the Study of Finance and Economics, CSFE, IMPRI Web Policy Learning, New Delhi. We are grateful to our experts for day 2, Professor Mukul ji, Ms. Urvashi Prasad ji, and Professor Pradeep K. Panda ji, for taking out your valuable time and giving an opportunity to the participants to learn from this online certificate course. We thank all of our participants who have actively participated in today's deliberation. We look forward to welcoming you for our third day of this certification course on 6th of July at 6:30 p.m. We are grateful if you are watching us on YouTube or listening to us on our podcasts or reading our publications. We hope you continue to join in future to our IMPRI Web Policy Talk and Web Policy Learning. Wishing you all a very good evening. Thank you.
Thank
Thank
you
you.
and good night.
Thank you, sir.
Mukul sir, if
Night.
you agree, we can start the next session half an hour before, as you suggested.
Yes, why don't we?
We
Next week.
can- yeah, next week. So participants will write about that. If you can
Okay.
join early, we can.
Yes, I'll join half an hour early.
Yeah, because sir is in Singapore, so late for him also. So if we can do earlier, that
Okay.
right. Okay.
So
Thank
that
you.
means
right.
next session we are going to have from 6 p.m. The
From
third
6
session next
yes,
Saturday.
next
Okay.
Saturday, 6 p.m. we can start so that we finish. We all can get a lot of time to discuss. And
All right.
thank you, Ranjan ji, because you have been discussing so good.
Thank you and
Thank
welcome. Good
Thank
night.
Thank you, Prasad.
Thank you, sir.
Okay. Dhanyavad everyone.